Thank you once again, Nepal Ophthalmological Society, for the kind invitation. We are definitely enjoying here. So my talk is on corneal tear repair. How many of us do see and perform a corneal tear repair regularly? Great. So Dr. Meenu told me to make it more for general ophthalmologists, so I've tried to cover the practical aspects that how we deal with these corneal tear or corneal lacerations day in and day out. So those of you who deal with this, we know that we keep on seeing pictures like this in your normal OPD, sometimes even limbus is gone. So suppose you have a patient something like this. After you do all your surgery or all the intervention and patient becomes 6/18, and with this kind of cornea, you would really love it. And if it's something like this and patient becomes 6/6, both patient and surgeon are extremely happy. So I'll just try to, in next 5-10 minutes or so, I'll try to see that how we can increase the possibility of having good outcomes. So I've divided this talk into what we do before we take the patient into OR, in OR, and after the patient is out of operation room. So corneal tear repair is not just suturing. There are a lot of things that we do before and during and after OR to have a better outcomes. So let's see what do we do before the patient goes into operation theater. So you need to evaluate in OPD as much as possible, because many times patient is not opening the eye fully. So as much as possible, you need to evaluate what kind of laceration is it. Is it a full thickness? Is it a, only lamellar that you don't need to repair at all? Or it's a full thickness, how the AC is formed, flat, what all things. Visual acuity is extremely important to document visual acuity, and if possible, a gentle B scan to rule out if there is any foreign body inside. Visual acuity becomes very important because sometimes these patients are medico-legal patients and your documentation needs to be very good. Counseling, extremely important. We need to tell the patient that what we are doing it for, document it, ensure that the patient signs over it, and a very good consent, detailed consent. We have a special consent for that, and ensure that we take the consent and tell them that it's only for, we generally tell them, we are simply repairing it, is not for the vision. We'll see how is it maybe later, whether there's a vitreous hemorrhage, whether there's an endophthalmitis, whether there's a foreign body, you need to evaluate it later. When do we post the surgery? Post the surgery for as early as possible. It's not that you want to wait. So maybe 4 to 6 hours, try to, post it, decide whether you want to do under general anesthesia or local. Majority of these patients you can easily do under local anesthesia, but if the tear is really big and, it's from limbus to limbus, you might have to post and take a quick fitness for general anesthesia. In case you are waiting, suppose the patient you are seeing in the night and you have to post the patient in the morning, please don't patch, no pressure patch, just a shield, no topical medication, give a systemic antibiotics and maybe tetanus toxoid, try to see what exactly it is, and then you post the surgery for as early as possible. So these are the things we need to do before we take the patient into OR, and it becomes extremely important for that. Now the patient has gone into OR. Now this patient is in the operation room. What do you do? So it's not that when the patient is in OR, you start suturing. It's not like that. You need to do a few things before you pick up that needle. So what is that? You need to evaluate it again, because many times you are not sure what kind of tear it is in the slit lamp, and you need to evaluate again and you do a wash. What do you evaluate for? What do you actually see in evaluation? See whether the wound is perpendicular, means anterior margin and posterior margin is same, or is it shelved? Whether it has an apex or not, whether limbus is involved or not. So perpendicular means the anterior margin and the posterior is in the same line. Shelved means it's shelved. So we'll understand why I'm saying so. We'll understand that when we start suturing. So here this patient had a full thickness here, and it had a small, in this area it was a shelved incision. So you need to know whether it's a full thickness or it's a shelved one. Whether this wound has an apex or not. So if whether there is an apex or it's just a linear wound. So sometimes there are 2 or 3 apex, like there's one apex here, one apex here. So you need to evaluate, so that will tell you how you are going to start suturing and which area you are going to suture first. Then next is whether limbus is involved or not. Whether limbus is torn or limbus is spared. Very important landmark when you start suturing. You need to see that limbus or sclera is involved or not. Last is, see how's is there an iris prolapse? Is there a cataract, vitreous in the AC? As a thumb rule, we try to avoid any intraocular procedure along with the tear repair. So as a thumb rule, we do only
corneal laceration repair in first go, and whatever other things that we have to do, please take it for a later. Even if that has to done, maybe sometimes the lens is really intermittent, you can take it maybe after 7 days, 10 days. But in a primary repair, do only repair, because suppose you are doing cataract surgery, you have a PCR, there will be whole communication, chance of endophthalmitis will increase. So these are the things which you will evaluate under the in operation theater, under the microscope, whether it is perpendicular, shelved, apex, no apex, limbus involved or not, and what are the status of intraocular things. Wash, very important. Before you pick up the needle, you need to wash it, because sometimes there is a lot of mud, dust, sometimes soot particles. So you have to ensure that everything gets washed. You don't want any foreign body to go inside while you are doing the suturing, So once everything is clean, then only you do it. And then sometimes these margins also, you'll have some kind of membrane, some dust. You need to clear it. You clear it completely. Spend some time for giving a good wash so that these margins are as clear as possible, so that when you suture, you have a best possible outcome. You might need, sometimes AC is flat, you might need to, do a AC reformation by using a viscoelastic substance from another side area. So once you have evaluated it, you've washed it, then you pick up your needle. And then what are the principles of repair? So see, once I'm suturing, so I need to take care of these 4 things. 1, restore the anatomy of the cornea or cornea limbal or cornea scleral, and ensure you have a good dome of the cornea so that you have a minimum possible astigmatism. And at the end of the surgery, it needs to be watertight wound. It should not be airtight wound, it should be watertight wound, and that's why I've kept it in red. That is very important, that you leave a watertight wound at the end. And then each laceration is different. So you can't have a thumb rule for everything. Each laceration is different. You need to customize the laceration repair as per that particular case. For sutures, you pick up 10 or nylon sutures, and needle has to be cutting needle. It's very important. It has to be cutting so that it easily goes in the cornea, and you don't have to struggle. And periphery, generally you have to take a larger bite. So if you have a needle which has a large radius of curvature, is good, but otherwise that's not a rate limiting factor for suturing. But you need to have a 10 or nylon, but cutting needle. So once you are doing suturing, so what are the things that you have to take care of? We generally follow this ALTR. What does that mean is, at the end of the surgery, you need to have a good anterior surface to surface apposition. There should not be no overriding. Otherwise, you'll have a Dellen and epithelial issues and so many other things. It needs to oppose surface to surface anterior, very good, no overriding, no gaping. Length will be equidistant from the laceration. What? If it is like the shelved incision, it will be equidistant not from anterior margin, because if you do it equidistant from anterior margin, you'll have some override. It should be equidistant from the posterior margin, which is very important. If you see where is the posterior margin, from there on the right or left, or below or up, it should be equidistant. That will ensure that it opposes well. For radiality, in that particular area, it should be at 90 degrees. So it will be in that 1 millimeter whatever you are repairing, at that area it should be at 90 degrees. How you sequence it? So if you have a perpendicular wound, you suture that first. Shelved you can suture later. If you have apex, so the apex will be the first area which you will suture, then the margin of that wound, and then the in-between area you will divide this, and so that you have a equidistant radial sutures all along. And if you have a Y kind of tear, you can use a pursing suture mattress, but I've used in the beginning, but most of the time I use interrupted sutures, which works beautifully well for me. If you don't have an apex, edges of the margin or edges of that wound will be sutured first, and then you ensure that how this thing is. And the length of the suture will be equidistant from here, and the distance between the two sutures will be the length of half of the suture, so that the compression zones overlap and you have a good apposition. So this is, I'm washing it. So since it has an apex, so first suture, so what I'm doing here is MVR and forming the anterior chamber with viscoelastic. Apex is the first suture that I'm taking, equidistant from the posterior margin. And then, 321 or 311 knot. It should be slightly on a tighter side, and generally the periphery sutures are on tighter, and as you come toward the center of the pupil, it's optimal tension. If you have an edematous area, please make the suture slightly tight because they tend to get loosened early. So after apex, the margins of the wound has been repaired or sutured, and then in between I'm putting this sutures, and the suture will be radial to that particular area. So in this area it will be radial 90 degree, in this area it will be 90 degree. So at the end you will look like these sutures are zigzag, but at that particular area it will be radial or at 90 degree. So, and if you have, wound is leaky, please don't, you should have a very low threshold in changing a suture and taking extra suture, but at the end it needs to be a watertight wound, as you can see here, and then you can place a bandage contact lens for so the patient is comfortable. If the limbus is involved, limbus will be the first area that you will suture. You need to ensure that the limbus is well opposed, and then only you take the next part of the suture. So I'll show you this video. So this, you can see the limbus has torn. So ensure that the edges are cleaned, ensure there are no membrane, and then you take first suture. It will start from limbus, it will come out from limbus. And this suture should be as long as possible so that it's very tight, so that you restore that anatomy pretty well. So if you have both this, so this suture is done, so this part of limbus is also torn. So the next suture will be again limbus. So you need to ensure that the limbus is, tight first. You can see this will ensure you have a good anatomy, and then you go ahead and keep on. So like in between that particular area, radial and then equidistant, as you can see here, this suture, this tear is like this. So I am perpendicular to this in this particular area, right? And then you ensure that from the visco, from the side port, you remove all the iris. There should be no iris that is left over in the wound, otherwise the chances of sympathetic ophthalmitis will increase. So as you can see, I'm ensuring that all the iris is removed from the wound. You swipe it over, and this is the end product that you see. Zigzag sutures you can see, but in that particular area it is perpendicular, and we try to make it equidistant and watertight. And intraocular status, I've already told you, cataract, vitreous, all those things we can take up later on. So you understood, before you pick up the needle, you need to evaluate it, wash it, and while you need what are the ALTR, and then sequencing, how you sequence it, ensure the margins, apex, limbus, those things are extremely important. Once the patient is out of OR, cystic antibiotics important at least for 5 to 7 days, topical steroids, cycloplegic, and B scan again you should do on first POD, rule out endophthalmitis, rule out any foreign body. And any further surgery you can take up later on where there's a cataract surgery. Keep watching for infections, because there can be infection, and wherever you have tenonylon, the chances of gram-positive cocci related infections are high, so ensure that you do it. Suture removal, generally after 3 months, because it takes that much time for the corneal wound to heal. But if the suture gets loose, you remove that suture early, because loose suture is a potential nidus for infection. And if you see a loose suture maybe 1 to 2 weeks, you can always take the patient again in OR and replace that suture. So I think this thing is clear, what all things you do before the OT, in the OT, and after the OT. As I said, each laceration is different, and you can definitely customize it. And if you follow this, 80–90% of the patients, they do generally well. There are lots of videos on corneal tear that we have put on this YouTube channel. You can access if you want. Thank you so much.